the Green Oak Expert Talk. I'm Shilpa Nagraj. I'm a clinical psychologist and a psychotherapist. I've completed my MPhil training from KMC Manipal. I'm currently working as a psychotherapist at the Green Oak Initiative. The Green Oak Initiative is a community mental health center. We are based out in Bangalore. We provide both psychiatric and psychological services that are easily accessible and affordable to the local community. It was founded by Dr. Samya Krishnan, psychiatrist, Dr. Ashlesha Bagadia, perinatal psychiatrist and psychotherapist, and Ms. Jwala Narayanan, neuropsychologist, who is individually bringing decades of their experience and distinct expertise, but also believes in strong and collaborative care. I would also like to share that Green Oak runs a low-fee clinic every Friday and provides medication management and also psychotherapy and conducts psychological assessment for the community who cannot afford. Our team also runs a free and confidential helpline to provide psychological support exclusively for mental healthcare workers, daily from Monday to Sunday, morning 8 to 10 a.m. and evening 5 to 8 p.m. We also have started COVID Rehabilitation Center for all the people who are experiencing post-COVID symptoms. You can reach out to us through the Green Oak official number. Today, we are here for the Green Oak Expert Talk. This is a part of our ongoing monthly talk series. It's a community event and open to all, where we explore various themes surrounding mental health. This being Borderline Awareness Month, we dedicate this month to spreading awareness, encouraging people to not hesitate in getting help, and ending stigma that surrounds borderline personality disorder. So we are very delighted to present Dr. Sivakami Suresh for the talk of this month. She's a consultant psychiatrist and psychotherapist, accredited CAT practitioner. She also has a post-graduation training from CMC Vellore and later in England. She's been working in Chennai since 2019 as an independent practitioner. She's currently practicing at Shantam Healthcare Center and Madras Center for Psychotherapy, as well as in Kanchi Kamakoti Child Trust Hospital, where she sees individuals in the adolescent age group specifically. She's also a founder and managing trustee of Madras Mental Health Trust. She believes making clinical services quite available for individuals and families from more socio-economically disadvantaged backgrounds. The trust also works in alliance with government and non-governmental organizations to make comprehensive and quality mental health care available to all the people. And she also runs a weekly psychotherapy skills group, a balanced group for postgraduate psychiatric trainees at the Institute of Mental Health, Chennai, with a bigger aim of making psychotherapy services available at each and every setting. And her interests includes improving psychotherapy provision, particularly for patients with complex needs, and improving mental health care services delivery systems to meet the needs of all the local communities that is present. So we are very grateful to have you, Dr. Sivakami. Thank you so much for being here. As we begin the talk today, just want to go through some of the housekeeping rules. I request everyone to keep their mic on mute during the talk. We have Dr. Sivakami Suresh, our expert speaker, begin the session, which would be about 50 to 60 minutes, followed by a brief discussion about the models and the theory around CAT. After a brief discussion, we would be discussing a case example, which is in line with CAT and borderline personality disorder. At the end, we would open the floor for discussion. So during the session, I request everyone to switch on their video, introduce oneself and raise their hands, or use the chat box for questions and comments. We have received a couple of questions on our registration link too. We would be addressing all of those at the end of the session. once again, thank you all for joining us, and welcome to the talk, and over to you, Dr. Shiva.
Thank you for that kind introduction, Shilpa. Hello, everyone. So I'll share my screen in a moment. Just wanted to say I want to thank Ashlesha and Green Oak for giving me this chance to speak to you all about cognitive analytic therapy, which is also referred to as CAT, in the context of personality disorders, more specifically borderline personality disorder. And Shilpa mentioned about this month being the PPD awareness month. And when I was thinking about that, I was thinking about a specific need. So perhaps Shilpa was talking about stigma and how, and in terms of accessing care. I was also thinking from a professional side in terms of more training or more interest to look at these difficulties, and along with maybe more acute conditions in routine clinical practice. So I was just thinking about this. So I'll share my screen now. Okay. Right. So in this talk, I want to think along with you all about a therapy model like cognitive analytic therapy, and how that can be used with individuals who may have a diagnosis of borderline personality disorder, or may have characteristics or traits of the same, even if not meeting all the criteria. And at this stage, I just want to acknowledge about how making a diagnosis has its own merits. At the same time, it also has its own challenges, and that's perhaps a bigger debate and something that can be discussed about. So I was thinking about how a diagnosis can enable persons to access the right care, to make sense of whatever is going on for them. It can also guide professionals to study effective interventions, and so it can be a guide on such accounts. At the same time, there's also an increasing recognition that somehow diagnostic categories may have failed those who are being diagnosed in some ways. So, for example, it does not necessarily consider the person's life experiences, especially early experiences during childhood or adolescent years, and how perhaps we should all talk about these difficulties in a more complex way, considering context as well. And for the purpose of this talk, I want to draw on the ICD-11 classification of personality disorders, which I find as a useful description, and I'm sure many of you have acquainted yourselves with it. So there are a few changes in the ICD-11 classification, and I'm also aware that some of you here my diagnosis may not even be the way you look at these difficulties, and you may be led in a different way in your practice. So in the ICD-11 classification of personality disorders, it takes a dimensional approach, and it classifies, so the classification looks at these difficulties in a mild, moderate, and severe sort of spectrum. And it also talks about personality as a set of patterns, so ways of coping in the context of one's early life environment, and in dialogue with perhaps stable temperament traits. So these are all concepts I'm very sure all of you all are very familiar with. I just wanted to set the stage by mentioning some of this. And so thinking about personality per se as a reciprocal mutual process, or development of personality as a reciprocal mutual process between early biology and the environment. And the classification has also removed specific types of personality disorder, and borderline personality disorder has been located as a specifier, because it's still found as a very useful description that can help us reach people who have these difficulties. So I have two objectives in this talk. One is to provide a brief overview of cognitive analytic therapy, And I will be using a case example to illustrate the core concepts and what this therapy can look like in borderline personality disorder. I've organized the talk into 4 sections. So the first one is introducing CAT, and then a bit of theory, the concept of self in CAT, and then about the core concepts in CAT, and then the case example, where we look at CAT's approach in personality disorders. So CAT is one among the integrated psychotherapies. It was developed by Dr. Anthony Ryle. Anthony Ryle was a general practitioner working within the National Health Service in the UK in the 1980s. So the model itself emerged around that time. I think Dr. Ryle was working in the NHS in its early days as well, in the post-war period when the NHS developed in the UK, as a sort of state-funded healthcare system. And I think this context is quite important for CAT, because my understanding is that Dr. Ryle was quite interested in having a therapy model that he can make available in a public health system, where maybe which at that point in time perhaps did not have many resources allocated for mental health. And when I came across the story of CAT, that certainly resonated with me when I thought about my training back in India, and when I thought about the systems here and the context here. And the model itself has evolved over many years within the NHS in the UK, and is also is being practiced in other countries as well. So CAT is an explicitly collaborative and relationally based approach to therapy. So, and this relational framework emerges from CAT's concept of the self. So CAT, another need that CAT was perhaps responding to is for a need for a psychotherapy that can provide a common language. So something about bringing together different schools of therapy, and to provide a brief and time-limited form of therapy. And at the time, and possibly even now, there are so clearly there are many longer forms of therapies as well that can be very relevant in specific scenarios. But CAT came up as looking at sort of matching resource to need, and in that sense, this time-limited form of therapy. So that aspect is sort of key in CAT, and something about thinking about cost effectiveness and using it in pressured healthcare systems. So CAT typically has a specific number of sessions contracted, and it could be anywhere between, so that's not 8, that's actually 6. So it can be anywhere between 6 and 24 sessions. And they're usually weekly sessions, with 6 being more in the milder end of difficulties, and 24 for more complex needs such as personality disorders. And CAT is being used transdiagnostically, and it can be used in different formats like individual therapy, group therapy, and couple therapy. And there is scope for family work. So CAT is and perhaps when I say more about the concepts, and when we look at the case example, this may become more apparent. So CAT is a very relationship-based framework. So it's and so sort of includes the system implicitly, even if we may not include. It's still individual therapy. However, we are always sitting with the system. So so there's scope to include family members as well and have joint sessions, and this can be relevant, especially in the adolescent age group. So just to summarize at this stage, it can be helpful for us to characterize CAT as doing 2 therapies at once. So one being more cognitive, problem and task focused, and one being more analytic, holistic, and person focused. So it's almost as if there are 2 levels of tasks occurring simultaneously. So which patients are suitable for CAT? So CAT is transdiagnostic, and we would think about which could be just the same for many other therapies. So somebody who is experiencing an acute episode of psychosis or other conditions like mania, or obviously their therapy is not the relevant intervention. At the same time, if somebody is unable to perhaps maintain sort of periods of abstinence from their substances, it may be hard for them to engage in something like therapy. Again, this can be discussed at length, but at least I suppose what they mean is something about, can someone attend sessions abstinent from their substance? Yeah, so, and you can think about patients in a spectrum. So some more milder problems, whether mild personality problems, or having specific circumscribed disorders or illness in that sense, like depression or specific anxiety disorders or dissociative disorders or somatoform disorders, and more sort of moderate and severe personality disturbance. And you could think about it as it might be helpful to think about people being on a continuum with regards to them being able to look at themselves or identify and talk about feelings, especially difficult feelings. And the second aspect would be, are they able to form a relationship with somebody else, which again becomes basic for any sort of therapy, and especially in CAT. So CAT can be used across the spectrum, and one of the aims in therapy would be to engage somebody's self-reflection and engage their ability to relate with someone, and to expand that would become one of the aims, especially in the more complex end. So now I've just said a little bit about CAT. Now moving on into the concept of self in CAT. Again, at this stage, you might all relate a lot of this with other theories of personality in other therapies. So CAT proposes that the self emerges within the intersubjective space. So at this stage, you might all be thinking about attachment theory, where talks about very similar things. And so CAT is an integrated form of therapy, and it has an integrated theoretical framework as well. So it brings together Kelly's personal construct theory, object relations theory. Sort of, it is described as a restatement of object relations theory in cognitive terms. And I think here I'll just pause to say a bit about this. So you could talk about it as restatement of object relations theory with an emphasis on the actual lived experience of the individual. So CAT views that experiences of somebody's childhood or whatever they've lived through. So there's a lot of interest in that. And the third source being the dialogic source. So where CAT draws on the work of Vygotsky, the Russian psychologist, and his work on social formation of the self, and Russian philosopher Bakhtin's dialogism. So this is the so bringing all of this together, I think it becomes like the sum is greater than or the whole is greater than the sum of its parts, that sort of thing. And CAT proposes that, and this comes from Vygotsky's work, where he emphasizes on whatever the happenings in that intersubjective space between a child and an adult. And I'll say a bit about that. So this slide might help us sort of connect with that space. So if you think of the adult sitting in the top, so it could be significant caregivers, family, the wider culture. So there's the adult, and then in the bottom is the child or the infant interacting with this adult. So Vygotsky proposes that the child develops and all the psychological processes like internal thought, emotions, beliefs, and so on emerge in this space, and it emerges in dialogue with this other. And the infant could bring their own inherited characteristics. However, one of the things about the infant is that this need for intersubjectivity, this need to relate and to grow inside that space. So Cat is quite interested in that dialogue. So this is just a quote from Bakhtin. So just as the body is formed initially in the mother's body, a person's consciousness awakens wrapped in another's consciousness. So something about the self developing in dialogue. And here dialogue sort of implies two participants, the use of a shared language and sort of a language that makes sense for those two people and may have a specific meaning in that way, and looks at the adult's role not just as explaining things, but more like these two persons sort of figuring it out together, and the child internalizing it. So maybe something like where the activities of the child, or starting from gestures to speech to movements, all of that gain sort of a certain meaning, and in turn the images they form of the world and of themselves evolves or develops in this space in partnership with the adult, and the child grows internalizing this dialogue along with attitudes, expectations. And at this stage, it'll be helpful for us to think about how Cat is also interested in wider culture. So not just individual caregivers, but also the wider society and the society's voice as well. So Cat conceptualizes the self as being essentially constituted and maintained by these interpersonal experiences acquired and internalized in activity, interaction, and conversation with others. So in this respect, it sort of departs from other more monadic understandings. So I'm not going too much into this at this stage, but if any of you are interested, we can talk about this later, or I can send you resources and things like that. But in that sense, Cat has this specific, proposes this specific concept of the self, which is a very socio-culturally formed self. So at this stage, I think I'll move on to talking about certain core concepts, couple of core concepts in the model. And then I think we'll take a break for some quick, if there were any questions, and then I'll talk about the case example. Because I already feel like, yeah, I'm just talking a lot. Right. So talking about reciprocal roles. So you'll find this word recurring in this presentation from here on. So reciprocal roles is one of the central concepts in Cat, and Cat's concept of the self sort of reaches clarity in this concept. So reciprocal roles, here the term role, so it implies subjective experiences. So it's quite a sort of dense concept where it typically denotes a state of being. So just somebody's state of being, which could include thought, feeling, action, posture, tone of voice, and other more complex psychological structures as well, like beliefs, expectations, values, and includes memory as well, and particularly relational memory. And it includes bodily states as well, because there's a whole lot of work now being done, and I'm sure there are a lot of you who might practice those forms of therapy as well here, where including the body in therapeutic work. And so the role here includes bodily states as well. And when you think about it, it seems like quite natural to do that, because very early experiences are more non-verbal. And so you can think of, for example, a baby being held by the father. So that's a very non-verbal sort of experience. And so roles include all of this. And the understanding in Cat is that, so these roles typically talk about, are derived, or they emerge from experiences in relationships. So particularly relationships with caregivers and significant others. So this could just be anybody, starting from parents, other significant adults, could be grandparents, aunts, uncles, whoever in that child's life, or siblings, older siblings, and later with whatever, in school, or it could just include any adult, and the kind of experiences this child has inside those relationships. So something about being the other to self, so being related to or related with, and how these roles can then become like a template that get played out internally, so self to self, and in turn interpersonally, self to other. So and how the understanding is that each person typically have a range of reciprocal roles, and that both poles can be engaged and occupied by a person. And so a set of reciprocal roles comprises the experience of the whole relationship, with a child derived pole and a parent or culture derived pole. So examples always make things clear. And so I have an example here. So I'm sure all of you have seen The Lion King. And here you have Mufasa and Simba. So you have Simba here being sort of perhaps shown, or to the entire animal kingdom, that to the entire or all the animals, and it's as if you have on one end the doing role. So you have the adults there sort of proudly displaying Simba, so proudly admiring this newborn cub, and on the other end, if you look at Simba, he's probably like, okay, what's going on? And so you have somebody who's I'm not sure how he feels, but something maybe we can assume that something about being admired, while also being very bewildered about facing this new world and all these different animals, right? And so this is an example of reciprocal roles. So something happening in this relational space between adults and the child. And it is a subjective experience. So it is about what that person is experiencing. And yeah. We'll continue to look at reciprocal roles, and we'll sort of keep coming back to it. But at this stage, I'll introduce reciprocal role procedures. So this is the other, reciprocal role procedures is the other concept in CAT. So procedures, or they're otherwise called target problem procedures. So it is a procedure is typically a cycle. It's actually it's very comparable to the cognitive behavioral cycle, but it's a cycle that can sort of which maintains itself. And the understanding is that these procedures are a coping or a response to the experience inside the reciprocal roles. And typically these procedures are set out as a way, they set out as a way to manage an experience. However, they can either be adaptive or they can become maladaptive and maybe symptomatic and patterns that do not work but hard to break. And a procedure is a cycle which has thought, feeling, action. It also has some other structures, like somebody's felt need, or this child's aim. What does this child need? What are they trying to do? That sort of thing. It also has other structures like assumptions. What is the underlying assumption that this child holds when they are entering this cycle? And there's feeling, thought, action, consequence. So I have here's another example. So as the story goes, as all of us have seen, you have a scene here where Simba's just lost his father, and so you have a pole where there's depriving, probably death, taking away his father, and you have a bottom role of Simba being deprived of his father. And you have the additional experience that Simba faces, additional experience of being blamed by his uncle. So something about where he begins to believe. So he experiences devastation, shame, and begins to believe that I am to blame. I bring shame to this pride. And it's as if the only way he can cope with that is to run away. So where what looks like he's trying to move away from his pain. And the only way the only option he has is to run away. And perhaps by running away from his family, he also loses and he deprives in turn his family of an opportunity to sort of figure out what happened and to maybe repair whatever, have a chance for repair. So that is on one hand. But he did have a lot of other experiences, meeting his friends and maybe growing up in a different environment and figuring out life in his own way. So, so this is just an example of a procedure, just for us to get acquainted to what the cycle can look like. And so CAT sort of it brings these concepts together. There's the reciprocal roles and these procedures. And in therapy, these are the things that we are interested in when we sit with someone and we try to understand their difficulties or see what's going on. I'm thinking maybe I can just pause here, or I'll just finish the multiple self-states model, which is about how CAT looks at personality disorders, and then we'll pause before the case example. So now I've talked a little bit about CAT, so about core concepts in CAT, how CAT looks at the self or personality, and here we have the multiple self-states model. So in CAT, this model, which is also called MSSM, so it is employed when working with individuals, particularly with borderline personality disorder. So here, the understanding is that the person sort of is constituted of different states, or they can experience different states of being. And here the term state has a specific, it refers to a specific thing. So a state is, again, it is a subjective experience of enacting a role. So for example, here again, going back to Simba and his experience of losing his father. So, and being blamed for that. So you have Simba here feeling devastated and blamed. And you describe this entire experience of him blaming himself as well and feeling blamed as a self state. And you could, maybe I called this as the outlaw. So, because, he was being asked by his uncle to run away as well. Apart from him running away, it was as if he was being, sent out of the group. And so here you have him engulfed by a particular mood, which is, or a particular feeling, which is shame and grief. And so the understanding is that a state is experienced primarily by the dominant mood. And the person could have varying degrees of access to whatever they're going through. So then varying degrees of awareness or being conscious of whatever is happening, and varying degrees of control as well at a given point in time. And self states can also be partially or completely dissociated, or in the sense completely removed from one another. So it's as if somebody can also treat themselves with respect, or if, say, Simba has experiences of being valued and being loved, it's as if in that point in time or that period, he cannot connect with that. And so when somebody is inside a particular self state, it's as if they're governed by that narrowly defined and extreme and intense affect. And the multiple self states model goes on to propose that in the more integrated self, when enacting one set of role procedures, the person is typically more in touch with the others also as well. So they are able to more connect, to select roles, to select procedures, having more control over themselves and the situation. and to switch between them flexibly and appropriately. So this is where the self is more integrated. And the understanding is that any child growing up with a good enough experience. So this term good enough, again, I think it's derived from Winnicott's understanding of being a parent. So when a child grows up with that sort of good enough experience, the expectation is that the child comes to possess a range of reciprocal roles. They have a wide repertoire where they can adapt to situations, right? And now thinking about more difficult and perhaps more extreme experiences where a child or a person and a person later on in their life can be left with fewer options characterized by extreme and negative roles, especially if that is when they've had neglectful or harsh and abusive relationships, and how the roles that they have, so they may have fewer options to begin with, and whatever roles they have can be very narrow and rigid, sort of leaving them vulnerable with unmet needs, with only few options, particularly in the face of stress, in the face of stressful situations. And goes on to propose that a certain coherence and integration is lost, particularly in the more severe end of the personality continuum, with persons experiencing themselves and the world as confusing and discontinuous. So somebody they could experience themselves in terms of distinct self states, and at a given point in time, one state could just become all consuming of the self. So Simba, it was as if he was he committed a crime, or he was the outlaw, and as if there was nothing else to him at that point in time. And somebody's being in life can also be accompanied by abrupt switching of states, and this could happen in response to internal and external events, and this can occur across minutes to hours to days. And so just to quickly say how, so for example, you could have somebody responding to a passing comment where they feel criticized and attacked, and then at that point in time, they're feeling so intensely anger or hurt that it's hard to recall any ever feeling cared for by this person, because the immediate experience is so overwhelming. So that's about the multiple self states model. And quickly to add, so here it proposes that the loss of a self-reflective capacity and a sense of agency, both of this require specific consideration, and it can raise particular challenges for both patient and therapist. And expanding such a reflection and growing a sense of continuity can be one of the many tasks in therapy. So this is how CAT begins to approach this group of this disorder. So before I talk about the therapeutic relationship, I think I'll pause here in case anyone has any questions, or if you want to say anything.
Sure, doctor. I think that was quite a good presentation of model of CAT. If there's any questions regarding the model and therapy, there is a theory of CAT, anyone can ask here.
Could you show the last few slides once more, please?
Multiple self-states model, is that what you're interested in?
Yeah.
Okay. Do you just want me to show it and leave it there for a few seconds and then?
Yes, please.
Okay.
Would this be applicable also, I'm wondering, for the dissociative DID? That's a thought I was having actually.
Yeah, I think this extends to explain that that sort of presentation as well. Yes. So a complete dissociation would be one where the person does not have any memory of that particular experience or their action, and or awareness. And a partial dissociation would be where they have partial memory and partial. So yes, it proposes, yeah, to explain that as well.
Thank you.
You can raise your hands or put your questions in the chat box. We can take it up for discussion. Meanwhile, we had got a question on the registration link, which was with respect to inclusion of children using CAT. Is there a separate conceptualization that is done with CAT, or how is it with children?
Right. So I think my understanding is that the CAT model is being used and has been used extensively in the adolescent age group. Perhaps it's arbitrary, it's more in the 14 plus or that age group, and not necessarily children, where maybe more systemic work or family therapy would be relevant. So the model is the same, except there's a lot of literature on engaging adolescents using the model, where you may have to sort of be very flexible where you start and what you want to do in the therapy, because CAT involves talking about the past, which sort of makes sense when you're sitting with an adult, and when you have an adolescent, that could be their present, right? So, and that teenagers may or may not be interested in talking about things in a sort of story that you want it to be. So I think there's a lot of interesting writing about engaging them more in the here and now. And but at the same time, I think look, in terms of putting down the reciprocal roles, or there it's pretty similar, like what you would do with adults. But I think it's more of a negotiation, or more of staying with where they want to be, which again is sort of implicit to the model. So the model, I think it operates in this concept of zone of proximal development. So to stay where the person wants to stay and to move with them. So there's a lot of nice writing about engaging adolescents, like maybe, because CAT also, which I'll show you when the case example comes, it's about using very ordinary language. So these reciprocal roles are usually, like you saw, it's just ordinary English, or Tamil or Kannada or Hindi or whatever that person may be wanting to use. And so with adolescents, sometimes I find myself sort of using maybe a movie dialogue or a song lyric or a character or those sort of things, whatever makes sense for that person. Because I don't know, teenagers may not want to, they may want to talk about whatever they want to talk about, right? So that allows for that. But in terms of the concept, it's pretty much, it's the same. And I think they've also modified, it's more collaborative in the adolescent population, more like where we would write. There are some activities like writing letters and all of that, where we would, it's more of doing with that person and not,
Okay. Thank you so much, because I think there are a lot more questions regarding work with adolescents, because I think you do have a clinic where you specifically work with adolescents. I think we can come back to it again in terms of specific aspects. But I think the interesting one was, having here and now and, relating to them at their, where their self states are. So I think it's quite interesting to know. Any other questions?
I'm also just moving the slides for Priyanka, and is that okay? Because I'm also looking at the time. Should I?
Yes. Yes.
Yeah. So can we move on to the next topic? We can come back to it.
Yes, yeah. So I'll just talk a bit about the therapeutic relationship and then take you through the case example. So just say about the therapeutic relationship, just like every other therapy there is, the therapeutic relationship is the sort of vehicle within which everything else happens in CAT, and more so given it's an explicitly relational framework. And so it is considered as a tool in itself. And the expectation is that it turns out to be a relationship that is quite active. So CAT is quite an active therapy. And again, I think that connects with its aspect of being time limited. So there's a lot going on within a few, within a defined period of time. And the expectation is that the relationship is non-collusive, equal, where the usual roles, so the usual roles that might play out in that person's life doesn't get played out. You have a therapist who can sort of step back and not enter into the typical roles that the person experiences in their life otherwise. You require a therapist who you expect to be curious, to bring their authentic selves and offer a different relationship than what is available for that person, and the relationship is within which all other therapeutic activities happen. And it's a very side-by-side doing with kind of therapy. And again, some of these could be very sort of common in other therapies as well. And CAT also requires the use of self on the therapist side. So it requires the therapist to use their self. And it requires the therapist to have a working awareness of their repertoire of reciprocal roles. So what they bring into the room, to have an awareness of that. And that includes, wider aspects like their own beliefs, values, and where they, and a very working knowledge, or where they might be at a given point in time with the patient, to be able to notice that and to move in and out of roles and to be able to talk about that. And it views the therapist and the patient as reciprocally influencing each other. So at a given point in time, whose feeling is it, to be able to look at that, to talk about that. So quite an active involvement from the therapist. So now to say a bit about the stages in CAT. So CAT therapy can be broadly divided into 3 stages that typically overlap and do not necessarily proceed in a very nice sequence, like the therapies. It's also quite messy. At the same time, it's helpful to look at it as 3 stages. There's the reformulation stage, recognition, and revision stages. So what I'm going to do now, hoping to use time effectively, is to talk about my case example and take you through the stages sort of side by side. So my patient, and before I talk about him, I want to thank him. So he's been very generous in giving me his permission to talk about him and the piece of work we did together for educational purposes. So I'm going to call my patient Rajesh. He is a 26-year-old man. At the time of assessment, at the time of his assessment, he was unemployed and he was in between studies. So he had completed his undergraduate degree and he was trying to prepare to sit entrance exams to gain admission into a postgraduate course. And he was living with his parents. So his difficulties started during his adolescence, around 18 years of age. So a brief description of his difficulties, a brief summary. So he has experienced at least 2 episodes of depression, severe in degree, associated with attempts to end his life by taking overdoses at the time. And he has received treatment, and he's responding, and his episodes responded to treatment to a certain extent, with treatment with medication, and on one occasion he received electroconvulsive therapy as well, along with the medication regime. And however, at the time of presentation, what was recognized was that he had never achieved remission. So he continued to have depressive symptoms. At the time of the assessment at the therapy clinic, so he was continuing to have symptoms at moderate to severe degree. And I'll say a bit about his, specifically about his difficulties. So over the last 8 years, so from the onset of his problems, he describes struggling with his mood as it fluctuates across a day, a week, or even within an hour. And he described experiencing an emptiness or vacuum on the inside, as if something was absent from him, almost physically, like a physical experience in his body. And he also described a pervasive hopelessness. He noted how his mood state was typically reactive to external triggers or internal thoughts or memories. And there are periods which were perhaps picked up as the episodes of severe depression. So there have been periods when the low mood intensified and was accompanied by marked degree of tiredness, appetite loss, weight loss, sleep disturbance, restlessness, and constant preoccupation with thoughts about the past, and where where he begins to isolate himself, cannot sustain his attention and complete any task. And he also experienced intense and recurrent outbursts of anger when he finds himself losing control, going into like shouting, breaking things. And these were typically triggered by interpersonal events. And he described struggling in friendships from his high school years onwards, with an experience of constantly being left out and a fear of the same, the fear of being left out. And so it was almost like a self-fulfilling prophecy. And he typically coped by doing more, so doing more for the other person, by being there for them over and above his own needs, only to feel neglected when the same was not reciprocated, or when someone did not reciprocate to that degree. And he did not have a routine. He was spending most of his time lying down. So he was someone who liked reading, and he tried to read at times. However, he could not really sustain his attention or concentrate for long periods of time. So he wasn't really getting through a book, which he used to be able to do. And he was someone who was also generally interested in literature, movies, and it was dark comedy, movies or books. That was almost his solace, like a way in which which allowed him to cope with some of his extreme experiences, which in a way supported us in therapy as well, especially early on. It was like a medium. And so here my task is not, of course, not to talk a lot about the diagnostic aspect, but just broadly, So broadly speaking, in his diagnostic formulation, two aspects were recognized. So there's a depression in partial remission, and then certain patterns in his personality were noted to interfere with and impair different aspects of his life. So a personality disorder was also recognized, and so this aspect was something that had not been explored with him in the past. And so that is with regards to the impression or the diagnostic formulation. And saying a bit more about what happened in the therapeutic assessment. So in the therapeutic assessment, it was as if the experience that I had was as if he was finding it hard to talk about whatever he was experiencing. And I found myself struggling to grasp what it was like for him as he went through these different emotional states. Overall, he appeared to be very polite and mild-mannered, and he was almost equally perplexed by his own difficulties. And in the assessment, when I tried to make some preliminary observations, he joined in sort of actively, and he was also interested to talk about his difficulties. And this is pretty much what I might be looking for. And so in a therapeutic assessment in CAT, these are the sort of things we might look for, just to see how that person engages and whether they want, what are their needs and how are they talking about their own problems. And he did, so after sharing with him about the sort of therapy about CAT, and so what I do routinely is to talk about it and then to give some printed information. So he was interested in giving it a go, and so we started regular sessions, and we contracted up to 24 sessions. So saying a bit about the first stage in CAT called the reformulation stage. So all of us are familiar with the term formulation. So whether it is diagnostic formulation or therapeutic formulation, it is sort of bringing together different aspects in somebody's presentation to achieve a certain diagnosis or to achieve a certain understanding, which may be underpinned by a certain psychological framework. So this is a formulation. And in CAT, I suppose what we are referring to by reformulation is that this recognition that any person who walks in with difficulties may have their own understanding of their problems. So it's like all of us have a hypothesis. All of us could have a hypothesis, and CAT or the therapy becomes a space where you may sort of reformulate or grow an understanding along with that understanding in partnership with this therapist. So the first stage, which usually in a 24 session CAT, it would be somewhere between 1 and 6 sessions, sometimes 8, depending on how, depending on the needs of the person. So the tasks here are 2. So one could be where you could call it as creating a joint description of this person's difficulties. So drawing the patterns. So here we're going back to reciprocal roles, where at this stage, we start noticing, identifying and naming these roles based on happenings in the relationship. So it could be based on the here and now, or it could be from the person's life as well, depending on where the person wants to be or what they want to talk about. And putting down these reciprocal roles is sort of a joint activity. So it's more of where you wander with the person, and it progresses very tentatively, and it gains clarity over sessions. So it's not necessary, it's like a draft after draft, and sort of finding out specific words that have specific meanings for that person and for the therapist. And typically we use patient's own words. There's no jargon per se. And one seems to be able to, so I particularly like this idea of using patient's own words, because it feels like language sort of using person's own words can allow us to engage with their world and their personhood in that sense. And there is also scope to use images or stick figures. So you might be working with someone who cannot read or write, and this helps there. Or you might be working with someone who likes to think in images. So it may be relevant there as well. And the other thing happening in the reformulation stage is to start talking about the past or experiences in relationships. So, and in a way, making sort of gradually links between the past and the present. So something about, in a very tentative way. So it's not a cause and effect, it's not an equation, but it's more like an understanding, and a very specific understanding. So it's a very subjective thing. So it's more about what it was like for that person. And it's quite an effortful stage for the therapist and the patient, because it involves a lot of wondering, acknowledging, an experience of sharing what may have been very difficult or even unbearable. And at the end of this stage, the hope is that the therapeutic alliance, it has deepened, or there's a certain shared understanding about the difficulties in light of past experiences. And again, I just want to add here, so CAT only offers a framework, and it's a very flexible framework. So it's not necessarily about coming up with a narrative to somehow, so I'm trying to say that the understanding is very, it's a very tentative sort of thing. So it depends on where the person is. So sometimes it might take all of the therapy to reach that understanding, or because it might be easy or difficult to talk about certain experiences, and so we try to stay where the person is and where they are able to stay, and the therapist so there's no sort of imposing understandings is what I'm trying to say, and maybe we'll talk about that a bit later. So for him, for my patient in the reformulation stage, what we started to try and notice and name different states so that he typically moved in and out of. So this is a list of the different states that he described, or that we sort of recognized together. So it was quite hard for him to talk about whatever was going on, but gradually between us, we were able to. And so he talked about this very depressed, useless state where life had no meaning, or he had no meaning. And there was another one where he felt completely numb. And then there's the bell jar. So now you might relate this with the title of the talk. So he described a specific experience where it was as if he was constantly switching off or disconnected from his present surroundings, something like maybe partially dissociating. But he would talk about it as if looking at the world through a bell jar. And he talked about a book by Sylvia Plath, the author, who also had mental health difficulties, and how she wrote about her depression as looking at the world through a bell jar. So I've never read that book, I'm meaning to read it, but yeah. So for him, that description helped him describe whatever was going on for him. So it was always as if he was watching and he was not inhabiting his present day. And he also talked about a fear where it was like any task, meeting friends, going for a walk, going to the library or sitting to study, all of that always felt like going to a war. So as if filled with fear, and he must hide. And there's also another state where it was as if he was giving, he was taking care of others, or he was constantly being interested in others. And that felt like the only purpose he had. So this is a photo of what it looked like when you use pen and paper in CAT. We start putting down words. So obviously I can't draw, but I do use figures. So this is how we started capturing the different states that he was experiencing and moving in and out of. So we started being more curious about these states, to know more about them. And his early therapy sessions were also an experience of looking through the bell jar for him, and how it was as if for him the world itself changed based on his mood, and how he can feel many different confusing feelings at once. Slowly, we also started talking about relationships with his family, and he talked about experiences of, different, so I'm not saying a lot about that, but broadly, he talked about, as if on one end, there was a lot of overprotection, or where as if he was reaching out for somebody's approval again and again, and he was restricted in that sense, although he was being sort of taken care of. But a space where it was as if nobody was interested in his own feelings. And at another end, he talked about experiences of, where unpredictable anger and lashing out, and between parents and towards him and with siblings. So a lot of challenges like that in early experiences. And he also talked about how in high school, he lost his grandfather. So when he was transitioning into class 11, which is quite a challenging phase for adolescents here, and how he was someone whom he had connected with while growing up. And he started talking about this beginning to feel alone, left out, and how he was always trying to seek these deep levels of friendship with others in his school, and always sort of crashing with and feeling cornered by peers when they weren't reciprocating the same thing. And around the 4th session, he shared about his experience of being sexually abused between the ages 11 and 15. And he talked about, it was quite hard for him to piece it together. So his own memory of all of it wasn't very clear, which is again very understandable when you think of going through such an extreme experience. So, but he was talking about this sort of crushing sense of shame, weakness, and this terror of not being man enough, and sort of he was able to locate it in his body as well. And he also continued to have nightmares and vivid and intrusive memories on a daily basis. So this was quite a difficult thing for him to talk about, and it was quite an experience for me as well to sit with him, looking through this. And somewhere towards the end of the reformulation stage, somewhere around 5-6 sessions, there was the sharing of the letter. So in CAT, we tried to put together whatever has been described, understood, like a synthesis, and the therapist writes a letter to the patient using just plain language and typically it's a synthesis of what has already been recognized and understood and nothing new. But it's meant to be a certain experience where you share that, and it can be quite a moving experience sometimes. Yeah, it depends. It can be, overall it's effortful, and you can have different responses from the person, from different patients. And typically the patient is also invited to write back if they want to. And again, these things can be modified if you're working with somebody who can't read or write. It's not like a set in stone sort of thing, but it's a task in the course of therapy. But however, reaching this understanding is sort of basic, and that's one of the early things that is happening. And this is what his map looks like. So you'll see all sorts of words here, just ordinary words, and you'll see different sets of reciprocal roles. So in the bottom, you have the more difficult ones, and you have the states. And you might see some Tamil here and there, because that's because he spoke in both Tamil and English, like most of us will be here. And in the top, you have the ideal sort of roles or in relationships, like where there's a very high degree of attachment, and that attachment being reciprocated. Or like with work, it's as if he had to reach this level of perfection, but without any connection to the work, as if he was doing his duty or getting somebody's approval. And in the middle, inside that circle, is meant to be more healthy roles, which are typically more accepting, connecting with himself, being there for himself, and in turn, him feeling more confident and being interested in himself and the world, and that sort of thing. And in the side, that's just some alternative self-talk and this emerges across sessions. So over 5-6 sessions, and sometimes it might be sticky notes that you take off that you can then write in a more final way. So, and it's a very shared work. So it's going back and forth. So there's ownership by the person also, and it's not something that the therapist creates by themselves. And this we put down to catch his experience of the abuse, and this we sort of placed it under the other map, because this was a very significant and difficult and big thing for him to talk about. And this was his procedure. So this is what we'd identified, how it's as if he was going between two poles of either, he can't even look at his, he cannot connect with his feelings, or he's bursting into flames, or like in that sense, becoming very emotional. And we were trying to stay somewhere in the middle where he can attend to his feelings in small chunks and be more interested in himself and that sort of thing, more interested in his feelings. So at this stage, I just want to say about how, when working with individuals with, borderline personality disorder, where somebody might typically experience themselves as very changeable and could be quite confusing to them and others. One of the tasks or aims in therapy can be to reach some coherence, and the reformulation stage can be, and there's a lot of literature about this as well, an experience where all of this is sort of brought together and held together. So the map sort of becomes like a third space where this can be put down and looked at and talked about, or sometimes not looked at. So sometimes people just want to tear the map also because it's like just too much, or it's just, so it's about finding the pace with that person, and so it's, yeah, it's, and then to maybe look at it as a very living thing, and not like, hopefully it doesn't become a fossil where it's just that, or like not like that. And people generally comment about gaining a clarity at the end of the reform and having specific goals of what they want to work on in therapy, and hopefully having included what was forbidden, like shame or more difficult feelings. And for my patient, this was an experience for him where he started talking about, so up until 7 or 8 sessions, around that time he started talking about feeling more understood, where it's as if he had a clarity about himself, although his problems had not changed vastly at that point. And the recognition and revision stage, here at this stage, the tasks involved, so you have an understanding, you have the map. So it's more about where you encourage observation and curiosity on the patient side as well. So so they bring instances about what's happening in life, and so you start using the map, looking at what's going on, and looking at using exits. So exits are typically any technique that can help with managing feelings or difficult thoughts or certain experiences. And this could be from a range of therapies. So typically therapists with other trainings can bring in their whatever techniques they may use into CAT. And so the expectation at this stage is that somebody is able to reflect on what is going on more, and they're able to start using some of these exits, become more familiar in noticing the roles they're going into, and the map can be a tool to this, and they're encouraged to do this outside sessions as well. So exits can be anything like simple behavioral programs like graded exposure, or practicing assertion, or alternate self-talk, or some distress tolerance skills, or identifying anything that might help that person, or using things that the therapist might be comfortable with. So for him, for example, even in the first session, we started using grounding. So just to help him stay connected with the present, and he liked that, and he started doing that in his outside sessions as well. And so that was one thing that allowed him to exit a particular emotional state. And this is what his exits sheet looked like. So these were things we identified over time. And the pause button is like typically pausing to connect to what is going on for me. So yeah, and I'm just looking at time. So this is what, so it can be a range of things that somebody might identify as useful. So for him, started with grounding, and then to engage in activities very step by step. And he started increasing what he was doing in a day very gradually. And okay, I'll talk about change, but before that, change that happened for him. Before that, I'll talk to you about therapy ending. So with him, we traveled through the recognition, and so the revision stage is typically where somebody starts making changes and coming back to therapy and talking about that. It's also about looking at what's not working, what's not changing. And so different people are going to be at different stages at different points in time in the therapy. And for him, he started using some of this quite actively. At the same time, he was also struggling a lot with certain of his experiences. And in CAT, therapy ending is also considered a very important experience. And in a way, we start talking about ending from the beginning, because the understanding is that this can also be an experience in that relationship. And it also acknowledges the limits of therapy. And we start thinking about how to use the tools that have emerged. And the expectation is that maybe the person can start being their own therapist and have some tools to keep going. So for him, we sort of prepared leading up to ending. We exchanged, so in CAT, you could exchange goodbye letters towards the end, where you think about what the therapy experience has been like, what has changed, what hasn't, what does it feel like to end, and how to keep going. So for him, around the 7th session, he started experiencing a relief. So that's how he would describe it, as if he can bear whatever has happened more. And he also tried some active exercises like no send letters, where he was giving expression to this anger that he felt towards his towards different people, actually. And he also found himself to be more active, meeting a friend. So he's someone who liked to write. So he started engaging with that. And he started using the map outside sessions. So he connected with the map. So sometimes people may not, but for him, he liked it. So he would start using it to recognize and identify states, sometimes only after it has happened. So he might have had an anger outburst, but after that, to sit and look at it, initially that was what it looked like. He was beginning to feel more contained. He was more aware of how he related with himself and others. And overall, he found that things were more manageable for him. And slowly, I think this was quite a key thing for him. He started experiencing himself as someone who can be there for himself. So it was as if he could be more in the middle circle. And he started getting involved in some studying, and he gained admission into a postgraduate course. So this was therapy over 6 months, which became 7 months, maybe, because towards the end, you could make it once every 2 weeks. And he did join the course, but he could not cope. And so at that stage, again, it was a different experience for him. It was as if he could connect more with what he wanted to do, which he couldn't do most of his life. And so he decided to quit, which was all very unusual for him. And he chose a different job that he found to be more suitable. So although he quit, he was very pleased with being able to connect with himself and to make decisions. And at the end of therapy and in his first review, he was thriving in his job, continued to experience difficult emotions and intense emotions, especially interpersonally. But overall, he talked about experiencing more stability, being able to deal with it. And so this is one scale that I use. A lot of you may be familiar with it. I think it's a tool that has like items that could be relevant across diagnosis. So initially, his score was something like 101. And I think something about more than 35 is considered as, needs help, that sort of thing. And opposed therapy dropped to like 48. So this is just one measure. This is a tool they use in the UK. I don't think it's validated in our population, but it's just something I use along with, just clinical assessment. And so that is him. So that was his experience of therapy, and that is the change he experienced. So in the goodbye letters, the idea is, like in other therapies, to be realistic, to acknowledge what hasn't changed also, and what to expect, and how therapy ending is almost a beginning to consciously help oneself. So do I have time? Yeah.
We have like 5 minutes to probably
wrap up,
and then we can take up questions.
Yeah, so I just have a couple of slides about the evidence base. Right, so we've talked a lot about, we talked about the overview of CAT, core concepts, stages in CAT, and with a case example where I tried to illustrate that. And now just to wrap up with mentioning some of the evidence base. So this is not comprehensive in any way. It's just a few studies that that there are. So there are many case reports of using CAT in patients with borderline personality disorder. There are studies that look at effectiveness of CAT in routine practice. So it's what they call practice-based evidence. And there are also controlled trials, especially as an early intervention for adolescents with traits or with more. Another huge debate about whether you diagnose personality disorder at all in the adolescent age group. But I think so I'm no expert in any of this, but I think right now the ICD-11 takes a sort of lifespan approach. So I think technically you can, but again, yeah, that's another discussion in itself. But yeah, so there is a trial looking into effectiveness of CAT in that group. And I think there's also there are what are called single case experimental design studies. That's quite interesting, I find. So they just look at one patient and systematically see the effect of therapy for that person. And this one I found quite interesting. There's one written by comparing mentalization-based therapy and CAT. And the article quite has a nice, I think, a conclusion. They talk nicely about how in these, different interventions, how we maybe organizing them in, differently in the course of somebody's treatment, and what a specific therapy can offer, what it doesn't offer. And so it's a nice article. And that's another, a study about the effectiveness of CAT in personality disorders. So you can look up any of this, and I'll also be happy to talk, share more depending on, what people want. So I think I'll wrap up there. Thank you, everyone, and I look forward to questions and some discussion.
Thank you so much, Dr. Sivakami. It's actually quite comprehensive and interesting to know a lot about CAT, especially I think the letters is something that stood out, and the examples that you gave using Lion King was quite relatable, to be very honest. Thank you so much. And now the floor is open for questions regarding CAT. Anyone can ask. You can raise your hand or put your questions on the chat group. We can take it up. Okay, I think Devashri has raised her hand. We can take her question first.
Hello, I'm audible?
Yeah, you are.
Hi. Okay, so first of all, I think thank you so much, ma'am, for this super comprehensive presentation. I'm a master's student in clinical psychology. We haven't really studied this yet, and this was my first primer introduction into CAT. Before joining the workshop, I read a little bit about it on Google, but I just wanted to say that you, I think, gave a very good overview of the foundation of CAT. And what I personally found extremely helpful is the case study that you spoke about. I didn't know that maps and letters could be used in such an effective manner, and the fact that your patient managed to find another job, and I mean all the information that you provided really helped me connect the therapy with the patient, I think. So thank you so much for that. There's definitely a lot of reading I think it requires, because I still am a little confused with the reciprocal procedures. I'm not fully sure that I understand that. But having said that, I mean, it was a very good presentation. So thank you so much for that. In alignment, I wanted to ask, are there, in order to practice CAT in India specifically, does one need any special supervision, training, licensing? Is it separate from your regular MPhil training?
Right. I suppose it's quite a tricky question, because I suppose CAT. Okay, I can answer it like this. So the practice of CAT is being generally regulated. So there is an association of CAT in the UK, and then there's an international association as well that has sort of members from different countries and from India as well. So I can mention my colleague Anne Teresa. She's a counseling psychologist, and she's also an accredited CAT practitioner, and she leads in this regard. And so I suppose there is no Indian Association of CAT as of now, and I suppose there's no regulatory body like that. But what we are, in terms of training, we're very few of us practicing CAT here, and I suppose a few years ago there were trainers coming from the UK, and there are people who have undergone, like who participated in the whole training and where they did the cases, and so they have been accredited in that sense. So I'm not entirely sure in terms. So this is the regulation generally available. So I'm not sure about how, yeah.
Right. There are no regulatory bodies in India as such. Got it. Got it.
Yeah. I suppose how I would conclude that is it like where you regulate yourself also, like how you, with regards to what certifications you have and what you choose to use in your practice based on that. Something like that.
All right. Understood.
And there may be others here, like maybe Shilpa or Ashlesh, people who can answer this better and help me out on this.
Right. Got it.
Yeah, just to add in, Debashri, I think any MPhil training would be for understanding of all the kind of therapies that is there. It would be definitely helpful to go and specialize in one of the therapies that you are aware of, and getting accredited and having a supervision group is something which is very important once you are specialized in one particular therapy. It could be MBT or CAT or CBT. It's about once your training is done, I mean, there will be levels of training. So once you give a exam or, however the procedure is, so once you do that, you can, then start, the supervision along the side and see the patient.
Yes, yes, and thank you for raising that. I suppose the key thing is supervision. So whatever you're doing, hopefully you'll have some supervision at a regular interval. You're able to look at what you're doing. That's what.
All right, that gives me clarity. Thank you.
Sivakami, I don't know if I missed that. You were doing some training, no, for CAT, like you were training some people, right?
So we started running introductory workshops, and at the moment we ran the Institute of Mental Health here in Chennai for the professionals there, and we're hoping to start a supervision group so PGs can start seeing patients. As of now, we don't have a setup where we can sort of make that more accessible wide in a wider fashion. And I think it's been 3 years since they ran the 20-day course, which leads into accreditation. There's the 20-day, so the 2-year course delivered in 20 days, and then because people came from the UK. And there's Anne also as a trainer. And
yeah.
We want to repeat it. At the same time, we are also trying to be more innovative to see what suits our context. Because I think at the moment, position ourselves alongside other therapies, and because we are very aware of the setting here, the scenario here, and so we're still working on that. Yeah.
Maybe we should think more about that also. How can we bring the training here but make it not only more accessible, more affordable also?
Yes.
And the training itself is quite, all these trainings are quite expensive. So
yes, thank you for raising that. So those are the sort of things we're trying to innovate on. And because there's a lot of interest from others also, but to come up with a model that suits us.
yeah.
Thank you. I hope you restart the training groups too, and so that people are trained can come for supervision too. I think we can go for the next question. Priyanka. Priyanka, can you hear us? Raise your hand.
Yes. So I was just wondering, with respect to the integration of self, the collage bit, right? I was just wondering, can that be also used for PTSD clients with, self-image as a concern there?
Will you just tell me more about what you mean self-image?
So any, whether it's complex PTSD or PTSD in that case, where a sense of self is a question, right? So I'm just wondering, the sense of self, or in other words, self-image, also along with sense of self. I'm just wondering, that integration bit seemed like it would be helpful in that area. So just wanted to check, what are your thoughts on it?
Yeah, so even if you think of my case example, I think for that person's trauma, you could call it trauma, and an overwhelming experience that threatens that person's integrity, physically and emotionally, at a young age, right? And it was something we were able to address using this model, and to name it and to include it as part of his self, and as not something that also ends up consuming him. So the hope is that it kind of becomes a part of his self, and to expand other more able or help or more adaptive parts. Yeah, it can definitely be part of this work. And maybe here I can add that, so again, I'm not an expert in this, but I know that working with individuals who have experienced trauma like that, in a sense of either repeated sexual abuse or any sort of abuse, or it's a broad topic, isn't it? So there are practitioners trained in therapies like EMDR who sandwich it inside CAT, and they may use it, specifically if somebody's struggling with a certain memory that is, part of themselves, that is somehow that needs to be addressed specifically. I think the understanding is that any of these techniques don't come in sort of in a vacuum. So it's not eclectic in that way, but it's more like it sits in that wider understanding that you've already developed and that therapeutic alliance that you already have. So people usually use it in the second stage or somewhere like that in the course of therapy. So there's a lot about this using CAT in PTSD or trauma like that. Does that answer your question?
Yeah, kind of. Yeah, thank you.
Priyanka, on that line, I think you've also had a question on the registration form. Would you like us to ask that?
Sure.
So, yeah, if you could ask how to use CAT to strike balance instead of functioning in extremes for the BPD client.
Yeah, that's a very topical question you have there, because we are thinking about BPD today. So I suppose the first task would be to recognize those extremes, and in CAT we would use the roles again, the reciprocal roles to acknowledge, recognize, name, put it down, have it as a, sometimes the map itself can be like a grounding thing, like where, you know, so sometimes in sessions I find myself holding on to it almost, even very literally, but yeah, so it can be a place where you locate these extremes and then wonder about it and think about it, and then to also continue to use that to recognize when somebody goes into those extremes, and then slowly where the person can start using that to recognize that, and and I suppose this is where I think that whole thing about top down and then bottom up as well, because what I'm learning using the model is that the map can be both top down and bottom up depending on how that person likes the map or not. Because sometimes when you're in extremes, the bottom up may be more self-soothing, distress tolerance, that sort of thing initially, before somebody can even access the map, right? So you marry all these tasks, and hopefully every person is going to go away with their own personalized sort of exits. So sometimes I draw an emergency box, like where we would put in all the things that can help when things become too much, which could include like holding ice, or I'm sure you're all using like DBT skills, that sort of thing. But then there's also the more slower activity of looking at what is going on, and you would do a lot of that within sessions first before somebody can do it outside sessions. And in that way, we are talking about the extremes, and we are trying to have a more balance, and also to acknowledge that it is a dynamic thing. So it's not a skill that somebody reaches and then it's there. So almost like that under stress, that somebody can lose that, and that's okay, and then to come back, that's all.
Thank you.
Thank you. I think we can go for the next question by Akisha. Hi, Akisha. You can introduce yourself and ask the question.
Yeah, hi. So I am a MPhil clinical psychology trainee, and I'm just wondering, like you said that, you know, in the therapy process, you use yourself, like, you know, therapist side self. So I'm just wondering, like, that is very I guess, you know, very different from other you know, who take a little, like you said, you will just, you know, give out your values, or maybe, you know, you take your values into consideration. So I'm just wondering if that creates that maybe that's challenging in some ways. I was just curious.
Okay, maybe I'll clarify here what I meant by that. So I suppose when we talk about using the self, it's just thinking about the therapist being aware of their own responses in relationships and what might be going on for them. So you could just go back to basic things like countertransference, transference, that sort of thing, where I suppose even in other therapies, those are recognized events, and the therapist is invited to be aware of those things. So it goes back to that, and it's just that in CAT, all that is located inside these reciprocal roles, right? And what we're referring to when we say about values or beliefs is that just to be aware of that. So, for example, just to be aware of how the therapist might respond to, say, gender-based discrimination or violence, or what they believe in or stand, where they stand, right? Not with a view to give that out to the patient, or not with a view to of someone, but more like being aware of, or say religion, for example, to know where the therapist stands. So I'll give you an example, maybe that might help. I remember how, so when I moved here after living outside India for some time, it was as if, yeah, this is something I can share. So initially it was as if I was reacting a lot to when I felt like if I had a patient who was a woman, it was as if I was reacting a lot when I felt like they were being treated badly or disrespected or something like that, right? Because it was as if I was like, this is not okay here or something like that. And then slowly I realized I had to back off. Like it was more me or what, and people actually like had their own ways of managing things, or the way they were looking at things were different. And if I can be blind to my reactions like that, then that can sort of shadow that person, right? So I think it's about sort of making space for both, and therapists managing to be curious. Having said that, I don't think any therapist is like neutral, value free, nothing like that. But I think I like CAT in the sense because it encourages us to be aware of it and to have control over it, or to figure out what you're going to do. How are you going to have more of a balance in, yeah. So I remember how my stance slowly changed, like where I backed off, and I'd be more curious about, okay, how are they? And I've been open to so many possibilities. I mean, and so many things really. So that, yeah. So does that help?
So, yeah, it does help. So it's like being aware of your own values and making sure that you're aware of what you are bringing to the table or the therapy process.
Yes. You can even think of it
so
as,
I understood something very different.
yeah. You can even think of it like what is referred to now even in life, no? Like think of your own bias or something like that. Maybe in very ordinary terms.
Yeah.
Just be aware of that, not to introduce the same bias, but to know what is going on.
Yeah. So a lot of self-awareness that's needed.
Yes, yeah, and in the accredited training, they require to have personal therapy.
Yeah, exactly. That's what I was going to. Okay. So thank you.
Thanks, Atisha. We have one more question by Dr. Soumya.
It is not so great, so my video is not on. Sivakami, thank you. I'm a psychiatrist. I work in Green Oak. And I don't know how much of it you got earlier, but CAT is something that I trained in when I was in the UK as well. So it's a modality that I'm very familiar with. And I was listening to you about, the letters and so on. And I don't know how many other psychiatrists are in the audience, apart from the people from our team. So I know Pranaya, Neelam, and Ashleisha and all of that. I feel like psychiatrists have this view that, CAT isn't for them, but I find that it is very applicable, I think, in a CAT modality. And I find it easy to write letters to patients. I mean, even the way I have to communicate, I find that it's very collaborative when I write to patients. As in, I got into the habit of copying all my clinic letters to my patients. So it kind of told them what I was thinking, but equally they're factual. So it was very validating for some of them. So it wasn't that I was doing CAT therapy with them, but doing CAT, writing those letters, thinking about snags, those reciprocal roles was fantastic. So I know, as much as I know CAT is for psychotherapists and psychologists, I feel like it's so useful for psychiatrists as well, the way it helps you think. So thank you. And I love the way you summarized everything. I mean, in 2 hours, I don't know, you managed to get all the relevant points. So thank you so much.
Yeah, and it's great to get to know someone else who's trained with CAT. Like, maybe we can chat at some point.
Cool. Yeah, sure.
Thanks, Soumya. I was just adding into the therapist self. I think Padma has mentioned about what happens in the movement of the therapy. In the therapy, it could be irritation, stuck or frustrated, which might be what the patient is feeling or intending to, or probably in a larger scale is patient is giving that kind of approach to others too. So I think you've told it quite clearly to be able to understand what the therapist is also going through moment to moment in therapy.
Yeah, so that's a very relevant point, and yeah, that awareness that we were talking about, the therapist using themselves, it does connect with that very much. So that's a very good observation.
We have one more question, Doctor, about, I think they're asking, would you be able to share the map or exit sheet with the patient after getting permission from the patient to help the young person or adolescent at home?
I think it's about sharing it with the parent. Yeah. So thank you very much for asking that question, because that is very possible, and I do that quite often, wherever possible, and I like to do that, because that means it's bringing the family in, and wherever it's possible, the map helps with that again. And we can have joint sessions, and we try to have that, especially when working with young people.
Yeah, that was me who asked the question. Shilpa, can I say a few words?
Please go ahead. Please.
And like Soumya was saying earlier, writing letters, I fully agree, is a very, very nice way of getting across. And thank you, Sivakami. It was a good presentation, and I quite liked it. And I can see that, as you say, you're not being purist, and you're saying that in the exit sheet, in the toolkit, you can use all kinds of things that you learn and know. Because I think gone are the days when you can say that you can be a purist in terms of therapy, and that you can give it a structure, but a lot of skills that you have and from different kinds of therapies that you have used, you do what suits the patient or what you think serves best. But I think you did it very well. Thank you. So I just wanted to check about this list sharing, because you often find that adolescents don't like it to be shared with parents. So with full permission, they may allow you to say certain things to them and to be reminded about certain toolkits that they can use, and not bully them, or they feel bullied, or kind of put down upon by the parent all over again. So that one doesn't want that also. Thank you. Thank you.
I mean, the hope is we try to get the sharing to happen within session or outside session, and mostly for the teenager to lead and to figure out what they want to do. Yeah, sometimes I hope for too much, but the parent to sort of join us and kind of become, and sometimes it may lead to, say, the parent having a few individual sessions, maybe with another therapist or with me, depending on resources. So yeah, but thank you for that question.
Thank you.
Thank you, Ms. Shubha. Thank you. We have another question on the registration form. I'm not sure if she's around Mom C. I think you'd asked about what would be the potential drawbacks of using CAT. If you could add in more for the question, or we can go ahead with this. I think. Yeah, Doctor. So it's about the potential drawback with respect to CAT.
Right. So that's always a useful question, to think about limitations or drawbacks. So I think with regards to CAT and in, say, borderline personality disorder, I suppose it might be about finding what the current need of the person is. So if you have someone who has a very severe degree of disturbance, who maybe needs like inpatient treatment, or like where they may be experiencing a high level of risk to themselves or others, or that sort of thing, I think more direct skills. So that's where I think the DBT model, it has a huge evidence base and it's used quite a lot. So the DBT, something like that might be more, it may make more sense to introduce that in the beginning. And when somebody, has more skills, or they can help themselves a bit more, and then maybe CAT can come later to explore or grow an understanding, and you could use the skills there as well inside that therapy. And I've seen quite a few services where they do something like this, where interventions are organized sequentially. And DBT or MBT, I think we have Ashlesha here who runs that sort of a program where you have maybe a group that somebody is participating in, and individual therapy can happen later or side by side or something, depending on, yeah. But I think cat.
Sorry about that, I'm muted.
So with so I think the limitation with cat is with regards to what is needed, I suppose. More than a limitation, it's about maybe matching the patient with the therapy, that sort of thing. But I think generally cat is being described as a sort of top-down thing rather than a bottom-up approach. So somebody may need more symptom-based direct skills. But having said that, I work in a community clinic like what you said. So I don't have access to many other resources, therapists or something like that. And I find that CAT also helps contain when you find the right pace. So I suppose you could think about limitations like that. And what else? Yeah, this is what I can think of at the moment, but maybe others can say something.
I think Dr. Soumya has a comment. Soumya?
Hi. So Sivakami, I think it was on the same lines that you've just brought up, that, it feels like a top-down approach. So like I said, I learned CAT, and when, thanks to Ashlesha, I came to India and learned MBT. So my initial formulations of patients, because CAT is so analytical, was very much about me telling the patient what I thought was wrong with him. So at times it didn't feel so collaborative. It felt like, this happened to you in the past, so this is happening. But when I did MBT, what it's helped me learn is to be curious. So my formulations are more tentative now, I wonder what that experience was like for you when this happened to you. So, and I like, again, going from what Dr. Shobha Srinath was saying, I like the fact that we're not purists, and you can't be purists, I guess we all learn different approaches and hold certain aspects of each approach. So like, I like the curiosity element of MBT, and I like the letter writing in CAT because it helps me understand the patient. And sometimes I've heard patients also feel understood and heard. So you're right. I think one of the downsides for me in CAT was that it felt very much like that power play was very much there. The doctor or the therapist was saying, this is wrong with you. It felt like that because,
okay.
But that's my comment.
Yeah, that's interesting to hear your experience. You asked about how it was for me. I think in my training, this whole equal thing and being curious or being tentative was sort of part of the approach, or although it's very easy to slide into that kind of seeing the patterns before the person can see it. And that can happen. But I suppose what I have found CAT sort of doable in the sense that when I back off and just kind of stay at a pace where it's possible for that person, and maybe also I think CAT also allows us to be quite flexible in the sense where depending on who wants to use what and things like that. So that way I find that helpful in terms of CAT. With I think so I'm not trained in any other therapy, and I attended, I think, one of Ashlesha's 2-hour teaching about MBT, and I also found it a very, very interesting approach. And I think it's definitely helpful when you're trained in more than one therapy, so you can do things together.
Yeah.
Thank you. I'm sorry, we are just running out of time. We will take one last question or comment.
Yeah, I just wanted to comment. Thank you so much, Sivakami. As always, it's always a pleasure to hear you and your views and the work you're doing. Just on I think we were kind of talking about the drawbacks, and I think this is a drawback with MBT and most therapies where a commitment to a longer period is required. And I think that, and again, it becomes a cultural thing, resource related drawback. That's definitely a problem we face. So our group therapy program is supposed to be 18 months long. And the first 2 cycles, we tentatively ran it for 1 year. And it's always, oh my God, will they stick it out for a year or not? And now we ran the third one because we became more confident in running it for 18 months. And, I think the duration of time required is something that if the client is not buying into it, then they may not last it out. And then it is up to the therapeutic relationship and how much effort we make and all of that. I also wondered about psychological mindedness because, like you said, I think in MBTI we do the same, like we have to match the level of the client. If they're in constant crisis and there's a lot of skill development that's required, they're not going to be able to sit and engage with you where you can do the analytical work or you can do the, visual work as well. But if you, I think like you said, you did a lot of work initially with this client, the grounding work was required and it was slow and paced at a pace that, he could take and you could deliver. And it's not always easy to do that. And you were able to do that and you were able to stay true to the therapy. But I wonder, how much of the psychological mindedness, how much pressure from the family, the cultural context, all of that can play a role in making it difficult to deliver the principles of therapy like we'd like to.
Yeah, that's a very helpful point because I was also thinking of what Dr. Soumya was saying about power. I'm still thinking about that. And what now you're saying about the pressure. I think I'll just respond to the pressure part. So I think that is something I routinely face. And what I've learned, what I'm doing and what seems to work for me is where it's as if sometimes in the initial 4 or 5 sessions, it is part of, so we bring that into the therapy as a, so everything is sort of thought about like that and it comes into the therapy. And sometimes I may fall into the pressurized place and get pulled, and then we try to talk about it later. So it may happen with a parent also. And sometimes it's as if we're going at 100 miles for the first 4 sessions, and then we find out we're crashing. And then you slowly get a moment where somebody steps back and they're like, yeah, I know, okay, this is happening. And then that happens almost a lot. And I think this may connect with the power, because I don't, in that sense, I don't use CAT as where I am coming up with the patterns and giving it to somebody. It is like very side by side, where if somebody is not even looking at the paper, I'm not writing on the paper, or I'm not I'm just also not looking. I'm like, okay, what's going on there? That sort of thing. So CAT allows that. And there's a lot of recognition that by the end of therapy, all you may have, what is doable and what is not doable. And we try to explicitly talk about that. But I also have support of a psychiatrist and couple of other psychiatrists who help with crisis management and that sort of thing as well. So, yeah.
I'm so sorry. It's quite interesting to carry on with the conversation. I also know that a lot of people would want to ask more questions. So if there is any more questions, please write to us. I am just putting our email addresses on the chat list, and we can send it to you, Doctor, with the responses, and you may, respond to it. So I think we have to call it a day here. And thank you so much for coming and giving this talk to us. And for a lot of us, CAT has been something which seems like it's inaccessible. You made it quite accessible, and it was quite relatable, is what I could say. And also, as all the process-oriented therapies is something that our field is heading towards. I think this would be very helpful if you can start with something supervision or training programs that all of us can benefit from. I hope all the participants, on behalf of all the participants, I think a lot of us are quite excited to know more about it. So thank you so much for being here today with us. And thank you all participants for joining us today. Please write to us if you have any questions. We can get back to you on the same. Thank you so much, Dr. Sivakami.
Yeah, thank you everyone. Thank you for having me, and thanks for all the nice questions and lots to think about. Yeah.